The next presentation will be given by Jonathan Hobby. He is going to talk about shared decision-making in Dupuytren's disease within the NHS.
Thank you very much, and I love that talk. Thank you so much. Very helpful. It's been a great meeting. I've learned a lot. So thank you very much to Ilse for giving me an opportunity to say something. I hope it's of interest. I'm a poor man. I have no financial arrangements to declare, but I do work with industry in my role as Head of Education for FESH, if that may or may not be a conflict. The cost of healthcare is rising, even in the socialist system of the UK, and there's a feeling in central government that they pour more and more money in, and it doesn't produce the desired results. Waiting lists go up. There's a level of exasperation, and the first part of this talk is about the financial constraints in the NHS. So in order to try and address this, there was evidence-based interventions consultation document. If you deal with the NHS at all, it's worth reading 1984, in that we do have a version of Newspeak. About the time this was published, the then Chief Executive of the NHS, front page article in the Times, this I found rather pejorative language, particularly when it was applied to carpal tunnel, Dupuytren's disease and trigger finger. Just for reference, carpal tunnel, the cost per QALY in the UK is about $1,500. And that is cheaper than almost any other regularly available treatment. And when we pointed it out to them, they shuffled their feet and didn't really respond. So the review of evidence was of poor quality, no attempt at a systematic review, and there was selective quotation of poor quality studies to justify the decisions they'd already made. And if you don't believe me, this is from the National Institute for Clinical Excellence, which is supposed to be an impartial reviewer. It's simply not true that 50% recurrence is common following surgery for Dupuytren's. The single reference that they quoted was for needle fasciotomy. So you see where we're going with this. Behind all this was, if you dug carefully, was a table looking for 40% reduction in activity for Dupuytren's trigger finger and carpal tunnel surgery. Just for reference, in the UK, we operate on about 1 per 1,000 population for carpal tunnel. Every other developed health system does about 3 per 1,000. So I don't think we overoperate. And rationing is my favourite word in all these conversations. The moment you mention rationing, they look really uncomfortable and start to wriggle. So we were sufficiently upset that we wrote a letter to the BMJ, which was published as a leading article and widely quoted. And it all went quiet for a bit, but new government, and it's all rearing its head again. So we have criteria for treatment, and actually these are agreed criteria for treatment. So though it feels a little bit like Big Brother's watching you, I think in this particular instance, this is completely fair and reasonable. There's getting it right first time. This is Tim Briggs, and this is basically a program to try and provide evidence-based medicine. I've been involved with this for almost 10 years. On the GIRF pathway, there is a GIRF website, there is a treatment pathway for Dupuytren's, and we've been through this several times. This will be familiar, but there's a hierarchy of options which are less likely to cause recurrence but have increased morbidity. So what the patient wants to know is how difficult will it be, how long is the recovery, how likely is recurrence, patient age is an important consideration, and what are the risks and morbidity of each treatment. And some people want to get back to work quickly. For them, a limited procedure is more appropriate. Other patients really want to try and fix that finger in one go, in which case a more extensive procedure, or even in some cases, primary dermofasciectomy may be appropriate. There's been a lot of discussion about what will allow us to predict the outcomes of our surgery and the risk of recurrence. And I think little finger is bad, and if they've had a good previous experience from a simple operation, it will probably happen again. If they've had early recurrence, you may need to do something more aggressive. So I think Baron Dupuytren, from what I've read of him, would not have been a great fan of shared decision-making. We wrote this decision aid in collaboration with the Winton Centre for Communication of Risk and Evidence in Cambridge. It was approved by NHS England and GERFT, and it's an 8-page document available online, so I won't dwell too much, but these are the 4 options that are considered. There's a summary of what's involved in each treatment, how long the recovery is likely to be. Then it goes through how likely it is to correct your finger, how long the correction will last, and how likely you are to have further surgery. And then there's a page on risks, which focuses on wound healing, numbness, and CRPS. There is also a page on other options, so steroid injection and radiotherapy is discussed. And then there's a page on just a little bit of the background into why people get the disease. I was pleased to be asked by the Dutch Hand Society if they could use this, and the Dutch have an online decision aid which takes you through it page by page in English. My practice is increasingly limited fasciectomy for most patients, with dermofasciectomy for the more severely involved and for recurrence. I haven't been a big fan of PNF, maybe I should try harder. So what we really want to know is how likely is it to come back. Diathesis is obviously a big risk factor. There are other things to be considered, but really the holy grail is a biomarker. So keep working, Charlie, please. So the mainstay of treating contracture is surgery. There are a range of surgical options. The optimal timing and technique has not really been established. Treatment decisions should be made with the patient. They must be made with the patient. And decisions should be made based on the quality of the correction, the morbidity of the intervention, and the likelihood of recurrence. We need robust evidence of the effectiveness of our interventions so that people will keep funding it. And I hope that many of you will come to Helsinki. Thank you very much indeed for your attention.
Thank you, Jonathan. I'm very glad that you allowed the Dutch Dupuytren Society indeed to translate the patient help. I think it's great.
They translated into English the version I found, which is really good.
I have it here in my backpack. It's a Dutch version.
Jonathan, when do you get your patients to look at that shared decision-making thing? Before you see them or after you've seen them?
During the consultation, I usually put it up and get them to photograph the web address. The other thing which has occurred to me, which I haven't done, is that it's very popular in the NHS to discharge new patients to a patient-initiated follow-up appointment. And this will bridge the gap between sending them away and them not being able to get back, which is what the NHS does really well, and satisfying our masters that we're using PIFU. So that is one of many things I'll take away from this meeting.